Okay, everyone, welcome to this launch event for Treat the Cause, a review of quality of care provided to patients treated for acute pancreatitis by the National Confidential Inquiry into Patient Outcome and Death. Now, this is actually a very important event because I think this is one of very few launches outside of London, so we're very honoured to be hosting this at the EPC today. So first, I'd like to welcome Neil Smith, who is the Deputy Chief Executive of NCEPOD. Thanks, Neil.
Thank you. On behalf of NCEPOD, I'd like to thank the organisers and the President of the EPC for allowing us to launch our report to this event. I would also like to thank everyone that's been involved with the study, clinicians that have completed questionnaires, case reviewers that peer review the cases, the study advisory group for designing the study, and our local reporters who are our contacts in every hospital who help provide data for the studies, disseminate questionnaires, collect photocopied case notes, and allow us to actually produce these national reports. So before I talk about the acute pancreatitis study, I'm just going to give you a little bit of background about NCEPOD itself. So we're an independent organisation. We were established in 1988 on the back of a King's-funded report looking at perioperative deaths. The emphasis of this report was on quality rather than causation of death, and this is something that's carried on through with NCEPOD for the last 27 years. The main focus of the NCEPOD studies is peer review, and therefore the remit of NCEPOD is to review medical and surgical care to make recommendations to improve the quality of delivery of care, and this is achieved by confidential surveys involving questionnaire completion and peer review. We then disseminate the findings in forms of reports, and our reports and recommendations feed into guidance and also provide support for clinicians locally and nationally to provide change within their hospitals. So one way of looking at whether or not we achieve our goal, achieve our remit, is to actually look at the impact NCEPODs have. And many of you may be familiar with the term CEPOD theatres. We also have been influential in improving the involvement of senior staff, making sure there's a reduction in inappropriate out-of-hours surgery, and I emphasise the word inappropriate out-of-hours surgery. More recently, our report on trauma care helped influence and strengthen the call for a National Director of Trauma Care, part of which his job description was to actually put forward and put in place recommendations put forward by the report. Our acute kidney injury report has fed into NICE guidance, and something similar is happening with sepsis at the moment. So hopefully this report now can have the same impact. So in total we've produced over 40 reports. The most recent before today was on sepsis, and then today we're going to launch Treat the Cause, which looks at the care of patients who had acute pancreatitis. So why did NCEPOD choose to look at acute pancreatitis? Well, as you all know, the management of acute pancreatitis crosses many specialties, has a high mortality and morbidity. Many patients will have recurrent admissions. The care they require is complex and often requires specialist input. And although there is guidance, whether or not these are implemented varies across the country. So like all NCEPOD studies, we then sent a questionnaire to the consultant responsible for the patient and asked some focused questions about this episode of care when the patient had acute pancreatitis. We also received photocopied case notes of the patient's episode of care, and these were peer-reviewed by a group of case reviewers. And we also sent an organisational questionnaire to each hospital that would admit a patient, so we could collect information about the facilities, guidelines, etc. in place for patients with acute pancreatitis. So in our 6-month study period, about 14,500 patients had a primary code for acute pancreatitis. When we applied our inclusion criteria, in other words, they had an inpatient stay of 3 or more nights, or admitted critical care and or died, we came up with a sample of just under 9,000 patients. Now, in order to not put too much workload on clinicians completing questionnaires and to overburden our local reporters, we then chose a random selection of 5 patients per hospital, and that gave us a sample of about 1,000 patients. We received 712 completed questionnaires, so completed by the consultant who was responsible for the patient at the time of discharge, or somebody who was more appropriate, and we received about 700 sets of case notes. Now, the data we're going to present to you is based on the 712 clinician questionnaires and 418 cases that were peer-reviewed by our case reviewers. Now, throughout the report, the denominator will change depending on where the data has come from, clinician questionnaire, organisational questionnaire, or the case reviewer assessment form, and also depending on whether or not a question was completed. So the denominator will change accordingly. Now, the main aim of this study was to identify remediable factors in the quality of care provided to patients treated for acute pancreatitis. I'm now going to hand over to Simon and then Derek, who are going to talk you through some of the findings of the report.
Thank you, Neil. For the remainder of the presentation, Derek and I are going to go through some of the key recommendations in the report and the data that underpins those recommendations. Apologise. So the clinicians caring for the patient stated that the cause of the patient's pancreatitis was gallstones in 47%, alcohol excess in 22%. There was a small number of patients with post-ERCP pancreatitis, but the standout figure was that no cause was identified in 17.5%. Now, you'd expect truly idiopathic pancreatitis to be less than 10%. Now, you might argue that these patients are going to have subsequent investigations which would determine the cause of their pancreatitis, but that would have to apply to almost half of these patients, and we know that the number of planned investigations post-discharge was actually quite low. So that doesn't seem to be the case. And it's clearly important to identify the cause of the patient's pancreatitis so that treatment can be started early and recurrent admissions can be prevented. So this graph shows the three common causes, groups, gallstones, alcohol, and unknowns, grouped by age. Over the entire population, the median age was 61, with the wide age range shown, and 55% of the patients were male. Gallstones was the commonest cause in those under the age of 30 and over the age of 51. Between 31 and 50, the commonest cause was alcohol excess, and patients with alcohol excess had approximately 20 years lower median age than the other two groups. Moving on to the patient admission. As you'd expect, almost all the patients were admitted as an emergency. The majority of the 1.7% who were not were admitted post-ERCP. 79% were admitted via the emergency department, and 21% either directly to a ward or directly to a level 2 or 3 bed. 56% of the patients presented more than 12 hours after the onset of their symptoms. We looked at those patients who had symptoms for more than 24 hours, and there was no difference whether those patients were a new presentation with pancreatitis or whether they'd had pancreatitis before. You might expect that those patients who had delayed initial treatment might have had worse outcomes, but we didn't detect any higher mortality or more critical care admissions in those who waited more than 24 hours to present. The majority of these patients are cared for by surgical teams, with 69% being admitted to a surgical assessment unit or surgical ward. 9.4% were admitted directly to HDU or ITU. Early warning scores are a simple track and trigger system that are designed to detect acutely ill patients at presentation or deterioration during admission. They should be applied to all acute admissions, including those with acute pancreatitis. NCEPOD first recommended their introduction in 2005 in the report An Acute Problem. So we asked the clinicians caring for patients whether they could detect whether an early warning score had been used in the emergency department, and in 31% they couldn't. Of those patients who did have an early warning score, it triggered a response in a quarter of the patients. That response was most commonly either a medical review or critical care or outreach review, but there were improvements in resuscitation, monitoring, and pain control as a result of the early warning score. Once the patient was on the ward, the use of the early warning score to track the patient's condition was better. 86% had an early warning score. And a similar percentage of patients, around a quarter, it triggered a response, and those responses were similar to those in the emergency department. So overall, 65% of patients had an early warning score performed both in the emergency department and on the ward. 8.7% had no early warning score in either location, and 8% had a different early warning score used in the emergency department from that was used on the ward. The use of early warning scores, different early warning scores across and within organisations will lead to a lack of consistency and in the detection of severe illness and deterioration. In 2012, the Royal College of Physicians recommended that the wide range of early warning scores used across the NHS should be standardised and the National Early Warning Score adopted. The ongoing care of the patients was tracked with early warning scores in 93% following admission. In almost half of the patients, the early warning score triggered an escalation in care. Again, that was commonly critical care review or review by other medical or surgical specialities. Now that may seem quite good, but when we looked in a bit more detail, 13% of those reviews were not sufficiently timely for the patient's condition, and then a further 7.5% the patient should have had a critical care review but did not. So we recommend that an early warning score should be used in the emergency department and throughout the patient's hospital stay to aid recognition of deterioration. This should be standardised within and across all hospitals, and NCEPOD supports the Royal College of Physicians' recommendation that the National Early Warning Score should be used to facilitate this standardisation. We also recommend that all acute hospitals should have local arrangements to ensure an agreed response at each news trigger level. That should define how quickly the response occurs. There should be a clear escalation policy so that we can be assured that the patient receives appropriate treatment irrespective of the time of day or day of the week. It should define the seniority and clinical competencies of the person who responds. And it should define where the ongoing care of the patient should be, including timely access to high dependency care if that's required. And it should also define the frequency of subsequent monitoring once the trigger level has been reached. We know that adequate oxygenation and fluid management prevents end organ damage and is one of the main goals of initial patient management. So we looked at those factors, and the reviewers considered that oxygenation wasn't adequate in approximately 5% of patients. They were even more critical of the fluid management, with 13% having less than adequate care management of their fluids. We asked the clinicians the same question. They were equally critical of the fluid management of their patients. So overall in this study, 22% of patients developed concerns about the renal function management in a total of 20 patients, and these were predominantly fluid resuscitation, use of oxygen, and failure to stop nephrotoxic drugs. Imaging forms one of the 6 of the 38 recommendations in the International Association of Pancreatology 2012 guideline collections. The IAP guideline recommends that all patients should have a right upper quadrant ultrasound when they are admitted with acute pancreatitis. 30% of the patients in this cohort did not have an ultrasound scan. Now, there may have been good reasons for this, and we looked at that. We excluded patients who had ERCP, those who had other investigations planned which would detect gallstones, those who were already known to have gallstones from CT scanning, or who died during the admission. There were 54 patients who'd had a previous admission, and we didn't have their notes, so we couldn't determine whether gallstones had been adequately excluded at that admission, but it did leave us with at best 44 patients who had no reason to not have an ultrasound, and 24 of these patients were diagnosed with alcohol-related pancreatitis. So we recommend that gallstones should be excluded in all patients, including those thought to have alcohol-related pancreatitis, as gallstones are common in the general population, and abdominal ultrasound is the minimum that should be performed. 60% of the patients in the study had at least one CT scan. Necrotizing pancreatitis was identified in 18% of patients, and an acute peripancreatic collection or pseudocyst in just under 13%. 13 patients had CT evidence of an infected collection. Now, the study advisory group were concerned that CT scans may be overused in pancreatitis, causing harm either due to unnecessary radiation or contrast nephrotoxicity. The reviewers looked at this issue, and they felt that in 6.6%, the number of CTs was appropriate. And when we looked at that 6.6%, half were due to too few CTs and half due to too many. So it seems that CT scans are being used responsibly in pancreatitis. In the opinion of the reviewers, 88% of patients had appropriate imaging. 48 patients had one or more imaging tests omitted, and the commonest test to be omitted was an MRCP. So we recommend that after excluding commoner causes of acute pancreatitis, those in whom the cause remains unknown should undergo an MRCP and/or endoscopic ultrasound to detect microlithiasis, neoplasms, and chronic pancreatitis, as well as rare morphological abnormalities. A CT scan should also be considered in those who have not already had a CT scan. At this point, I'll hand you over to Derek.
So, thank you, Mr. Chairman, ladies and gentlemen, and once more to the EPC for providing us with this opportunity to present this study. So, antibiotic use in acute pancreatitis was once a very controversial topic, but it's become less so since the IAP guidelines, which clearly state that the use of antibiotics should be restricted to suspected or proven infections and not used in a preventive or a prophylactic manner. So perhaps it will surprise you that 60% of the patients in this cohort received antibiotics during the course of their stay. Now, we asked the clinicians for the reason they prescribed antibiotics on each occasion, and the commonest reply was, "I don't know," and that's the non-specified category that heads the top of the list. And the second commonest response was, "Because the patient has pancreatitis." Now, I put it to you that neither of these are good indications for the use of antibiotics. There were, of course, a number of legitimate reasons why antibiotics were prescribed, such as proven biliary, respiratory, or urinary tract infections. But there are a number of what I think are worrying indications, such as an isolated raised temperature, raised white count or CRP, or pancreatic necrosis per se in this non-infectious disease. And so when we asked both the clinicians who cared for these patients and the case reviewers what proportion of cases they thought had inappropriate antibiotic use, they came back with an almost identical proportion. That was in about a fifth of cases. It was considered inappropriate antibiotic use. And by inappropriate, it was almost universally because the antibiotics were not indicated. So, misuse of antibiotics causes harm, most importantly through the emergence of resistant organisms, as well as being a waste of healthcare resources. So we very much endorse the IAP view that antibiotic prophylaxis should not be used in acute pancreatitis, and very much endorse the concept of antibiotic stewardship, and that such policies should be in place in every institution. Nutrition today is an essential component of the therapy of acute pancreatitis. And I'll begin this section with some good news. The proportion of hospitals which have a nutrition team available is 87%. Now that's good news, because when we asked this question previously, such as in our 2010 report on parenteral nutrition, the corresponding figure was 60%. So clearly there is and can be organisational improvement, and it seems to have occurred during those intervening periods. It's not all good news though. Nutritional assessment is something that NICE recommends every patient have on admission, and that this be repeated on a weekly basis. And between 14 and 23% of cases, this was considered not to have been done adequately. And that's either because it was delayed or because it was not done at all. 33% of individuals in this study received a dietitian referral, but it's of interest that of those who didn't, the clinicians themselves considered, or the reviewers rather, that 27% of those would have benefited from a dietitian involvement. An overall assessment of the nutritional management incorporates the initial assessment. It includes the appropriateness of dietitian or nutritional team support, and the adequacy of supplemental nutrition provided. And this was considered not to be adequate in 15% of cases. And it seems to me clear that this is an area where we could be doing better. And so our recommendation very much focuses on the importance of that initial nutritional assessment. And a tool such as MUST provides a very good basis for doing this and for triggering subsequent dietitian involvement and supplemental nutrition. So, as you'll have noted, the title of this study is Treat the Cause. And that's for a very good reason. 20% of these cases were readmissions, repeat admissions. And these were across the board, 56 readmissions with the same diagnosis of alcohol-related pancreatitis, 34 readmissions with the same diagnosis of gallstone-related pancreatitis. So why do we have this problem? Well, one of the first answers is because only nearly 19% of cases underwent definitive treatment of their gallstones during the index admission, as would be recommended by the IAP. Of course, that may not always be appropriate, and there are legitimate reasons why this may not have occurred, such as ongoing severe pancreatitis, or the patient not being fit for surgery. But clearly, lack of access to emergency theatres is not a legitimate reason to avoid performing a cholecystectomy. And why we have this problem with access to emergency theatres is explicable when we examine the returns from the individual organisations. It is good that slightly more than half of hospitals have policies in place whereby they wish to see cholecystectomy being performed either on the index admission or within 2 weeks. But it's certainly worrying that about a fifth say the policy is to prioritise them, but not within 2 weeks. And it's even more worrying that another fifth say they don't prioritise them at all for this indication. And so our recommendation echoes that of the IAP. For mild acute pancreatitis, patients should have their gallbladder removed on the same admission, or if they are fit to be discharged within 2 weeks. And clearly for those with severe acute pancreatitis, this will depend on patient fitness and resolution of their pancreatitis. And this is the same problem with alcohol-related pancreatitis, which, if treatment and support is given, can also be a treatable and preventable cause. And this data shows that of those with recurrent admissions with alcohol-related pancreatitis, the clinicians or the case reviewers couldn't determine whether a referral to an alcohol liaison service occurred in about half the cases. Part of the reason for that is because only 80% of hospitals have an alcohol an alcohol liaison service. So again, this seems to me a very strong opportunity for improvement and time for clinicians to not merely respond to the consequences of alcohol misuse, but to deal with the underlying cause itself, that is, the alcohol. And our recommendation states that all those admitted with alcohol-related pancreatitis should be referred to their hospital alcohol support service. And moreover, that we should make as much effort to deal with this underlying cause as we attempt to do for other causes. And this is a real challenge to organisations such as NICE, such as the IAP, that this be placed in their future recommendations and in their future guidelines and guideline revisions. So, as we know, the treatment of acute pancreatitis is becoming increasingly complex. And it's for this reason that specialist centres are required, which can provide the full range of interventions and treatments, and that these specialist centres need to operate closely in a network with their local surrounding hospitals. And the reason for this is one of equity, and it is so each patient can access life-saving interventions regardless of which hospital they originally present to. And that is not the situation currently. Only about a third of hospitals stated that they were part of a formal network of care for acute pancreatitis. And of those that weren't, 75% said they were part of an informal network. Now, the truth is that an informal arrangement is not adequate in a condition where deterioration can occur at any time. But it's quite alarming that a quarter didn't even have this degree of organisation and cover. And the reason we need networks and specialist centres is because only 27% of hospitals stated that they could provide interventional radiological drainage of the pancreas on a 24/7 basis, and only 30% stated that they provided surgery in acute pancreatitis. These were the interventions performed on this group of patients, and you can see most interventions are radiologically placed drains. There's a smaller proportion who underwent surgical necrosectomy, either open or percutaneous. A small number had endoscopic drainage or endoscopic necrosectomy, but we do know that this is a modality that is rapidly increasing in popularity in recent times. So our recommendations is that specialist tertiary centres be properly commissioned for the management of this disease. And we have a definition from the IAP. They're high-volume centres which have appropriate intensive care facilities and 24/7 access to interventional radiology, endoscopy and surgery. And we do already have a model for this in the UK, and that's the Improving Outcomes Guidance Compliant HPB cancer centres. And that's because they already meet service specifications and peer review requirements for adequate radiological and surgical cover. So I come then to the final outcomes for this group of patients. And nearly 80% were discharged back to their original place of residence. Mortality rate, 13%. Now, just to clarify, I'm not saying the mortality rate for acute pancreatitis in the UK is 13%. I'll refer you back to the inclusion criteria, which meant that this is a group of patients with a more severe disease. 5% were subsequent hospital transfers. So the key component, and I think the real strength of NCEPOD reports, is the peer review that we subject this care to. And this is provided by clinicians on a voluntary basis who grade the quality of care that they provide and that their peers provide. And part of that peer review is to assess the overall quality of care. And in this report, nearly 45% of cases received good care, and good practice was determined. Now, the criteria for this is that this is a standard of care you would expect from yourself, from your trainees, and from your institution. That's what it means. Clearly, there are other proportions of patients that where room for improvement was identified, whether that was clinical, organisational, or both. The less than satisfactory category means that this falls well short on a number of measures below that which you would find acceptable if provided by yourself, your trainees, or your organisation. And this occurred in 2.8% of cases. Now, just to put that number in context, 2.8% less than satisfactory, of course, is never acceptable, but it is on the lower end of the spectrum in comparison with previous NCEPOD reports. So, in conclusion, Mr. Chairman, ladies and gentlemen, I would first like to state that this report highlights a lot of good care being provided throughout the country. And this is at a time when the NHS is under considerable financial pressure. So there is much good news about the quality of care we provide for acute pancreatitis in this country. But the report is far more complex than that, and there are areas where we could be doing better, and most notably in our failure to deal with the underlying causes in so many cases. We've identified a large number of areas where there is opportunities for improvement and provided practical recommendations to achieve this improvement in care. And now I very much hope that all of you will play your part in helping to implement these recommendations. Thank you very much for your attention.
Okay, my name is Richard Charnley. I'm a pancreatic surgeon in Newcastle, and I'm joined on the podium with my co-chairs, Chris Halloran from Liverpool and Steve Pereira from London. We'd just like to draw out some of the points, and I think one of the really important points to make is that this type of report from the National Health Service sponsored organisation is actually quite a common thing in the United Kingdom. I'm just saying this for those of you who are from other countries. The NHS really specialises in making sure that the quality of care is equal across the country. And what we're really keen on is to make sure that no hospitals actually drop below a level of care which is unsatisfactory. And so, whereas in some countries you'll see a lot of publications coming out of highly specialised centres, if you look very carefully at what's happening in the lesser well-known hospitals in some of those countries, some actually very bad things are happening. And in the UK, because of the National Health Service, we pride ourselves to make sure that that doesn't happen as much as is possible. This report is actually very important for the NHS. It's highlighted quite a lot of issues. I actually think the bar has been set very highly by our assessors, which is absolutely excellent, because what the NHS will now do is take this forward and ensure that those standards are reached. NCEPOD actually carries quite a lot of weight, and it's actually a boot. And it will put a boot up the backside of quite a lot of NHS hospitals and the chief executives of those hospitals. And that's a really good thing. So on Monday morning, I'll actually be knocking on the door of my chief executive. He's actually been in the post a very long time, so he's had quite a few boots up his backside already. But this boot will actually be quite effective. So I'll move on to Steve. And Steve, perhaps you'd like to make a few comments, and then we'll take some questions.
Thanks, Richard. I'd agree very much. These are very powerful data, and congratulations to all the people involved and the clinicians around the country from, 195 hospitals, I think. So really powerful data, and it's reassuring, I guess, that poor practice, or at least suboptimal practice, is so uncommon in the report, of only 3% perhaps, and that's a good thing. I like that very much. It also gives us very strong guidance about where to improve things, and I think the fact that 20% of patients are being readmitted to hospitals with pancreatitis is something that needs to change, urgently, and that involves early surgery and defined maximum 2-week periods, and that's something that we can all act on very quickly. I have questions about how it goes from the recommendations to implementations. Also, many other areas, of course, in terms of defining risk assessment. I think that's very variable, even in our place. Use of a benign MDT, we've concentrated very much nationally on cancer MDTs, and that's really defined our surgical and medical practice in many hospitals, to, I think, the detriment of people with severe benign disease, and that we need to sort of improve that balance somehow. So I'll leave it there. Thank you.
I'll just make the first little... You knew I was going to do this, Derek. So, I mean, the four of us, yourself, Richard, Steve, myself, all work in what we think are very mature hubs with a well-developed spoke network. But it costs a lot of money to look after these patients, and I think our most recent analysis is that we probably lose somewhere between £30,000 and £50,000 on a complex patient, and we're under a lot of pressure not to do that. And how do we go about this with the commissioners, do you think, Derek? Because that money will have to come from somewhere, and will probably come from other patient care groups.
Well, I mean, what you've got now Chris, that you didn't have an hour ago is an NCEPOD report which will help you in your discussions with commissioners. The whole issue about funding of a service sounds very familiar to me about the debate we had when we organised trauma properly in this country, and the first thing Keith Willits did when appointed as he was called National Trauma Czar, it's quite an appropriate term for him, was to look at the tariffs and, without increasing the amount of money spent, to ensure that those with the more severe injuries who consumed most of the healthcare resources, that the tariff matched the severity of the disease. And something very similar could and should be done in commissioning of pancreatitis.
Okay, should we move on to any questions from the floor? Yes, please.
I'm Wei Huang from Liverpool. Just one question. So on what scientific, two questions actually. On what scientific basis that you are recommending the early warning score?
On the basis of the large evidence base for this that exists nationally, that this identifies patients who are deteriorating, at risk of deteriorating, and it triggers a response. And all that evidence was very much replicated in this study. We showed that when it was done, it often triggered a response, such as more senior review, critical care outreach, escalation of care. So when it happens and it triggers often in severe disease, and it triggers really useful responses. It is simple, and with a national system, staff can get very familiar with it. And I think the most successful hospitals in the country really place the greatest evidence on this concept of rescuing patients from deterioration, and the news facilitates that.
Okay, I'd strongly agree with that. We actually use early warning system for all our inpatients in Newcastle, and that's been very effective. Okay, any other questions?
Sorry, did you have a second question?
No, second question is actually a comment, if you allow me to say. When you say that for example, moderate or severe patients that consumes most of the NHS resources, actually, if you look at patient population for prospective recruited patients, that more than 70 or 80% of them are mild patients. And also those patients, actually, if you see the cumulative hospital stay, and they are more than the moderate and severe patients, which accounts for probably around 20%. So while we are improving the care for moderate and severe patients, we still have to reduce the mild patients' hospital stay.
Do you want me to comment on that?
Please, Richard.
I've been involved in commissioning of healthcare, and I've sat on the HPB CRG, which for those who don't know what that means, it means the sort of reference group for commissioning or government funding. And you're absolutely right. The funding in the UK for patients who have acute pancreatitis is actually very complex. If you end up on intensive care, then you actually get funded per hour of organ failure. So if you've got two organs failing, then your hospital is going to get more money than if you got one organ failing, etc., etc. If you're actually on the ward, on the surgical ward or a medical ward, then the funding is due to the procedures that are done for you and not due to your being there. And so this is where the problem comes in funding, and this, I think, is going to be, following this report, it'll be extremely useful to address this. Thank you.
Sorry,
I think we'll move on to other questions. Thank you. Was there one behind you?
So thank you for your question. The percentage was 5% were transferred. So it's not 5% of all patients with acute pancreatitis being transferred. It's 5% of this cohort, which are a more severe group. We hope that the report will stimulate a more robust system of specialist centres and their engagement with local referring hospitals, and that be put on a formal footing. And there are lots of models where this occurs, and it seems to me neurosurgery is a very good example, often backed up by an electronic process. And this is the sort of level of organisation we need to move to. But of course, nobody's saying it's going to be easy. This is the beginning.
I think the other thing to say is generally in the UK, we have accepted that non-interventional management, that is basically intensive care and basic support, is done in a very satisfactory manner in outlying hospitals. And that's because we've trained people up in the centre and then they've gone and got consultant jobs in outlying hospitals. So the quality of intensive care, certainly in the part of the country where I come from, actually is very high in our outlying hospitals. And so we actually keep patients in the outlying hospitals and we transfer them if they require intervention. And we actually provide what we call a remote care service. So we actually encourage referral of patients to us while they're in the outlying hospital. We don't transfer them unless they need intervention, but we look at their scans every week, we look at their parameters, and we monitor the situation. And this is very much a partnership between clinicians in the outlying hospitals and at the centre. And I think that's done in quite a few centres.
Absolutely. I think just to add to that, I mean, one of the outcomes of this I would see is that as we've sorted out cancer MDTs around the country, that all patients with suspected or proven cancer are discussed in a multidisciplinary environment. That should also happen with a subgroup of people with acute pancreatitis, so that people in the district hospitals have access to tertiary centres who have all the implementation to do that.
Vijay Singh, Mayo Clinic, Scottsdale. I have a question regarding formal regional care network. It's a concept which I'm not very clear about. First, to understand what does it really mean. And the implications I understand could relate to if there is such good care provided at the local hospitals, like the intensive care. And since most decision making in pancreatitis, unless it's cholangitis, for example, once the patient is in the hospital, it doesn't need to be done 24/7. It can be usually deferred by a few hours or several hours. Why do we emphasize a 24/7 service for intervention if there is such good care available, and how this fits into the formal regional care network?
So, again, thank you for your interest. It's great to hear from a different care system. Excuse me. I think the essence of what we mean by a formal network of care is very much the 24/7 concept. And we all who manage acute pancreatitis have patients who bleed. And then you do need to be in an institution where you have 24/7 interventional radiology to do an angiogram and embolize and save that patient's life. Now that's the quality of care we aspire for all to be available for all patients in the NHS in the UK.
I think the other thing to say is that, I mean, you're absolutely right in that actually there aren't many interventions which are done in the middle of the night. But if you think about the weekends, for instance, we very frequently ask for a radiological drain to be put in at the weekends. There's a patient whose drain is blocked or something, and they've gone septic. They need doing before Monday morning. And also ERCP as well. I think it's important, but yeah, not many of these patients are done in the middle of the night. Okay, any other questions?
Well, I'm sure we're all eager to get to the dance-off, whether we're willing to or not. But I think Derek and Neil and Simon have produced an outstanding document that will give us much food for thought over the coming days and weeks. And as Richard said, many knocks on chief executives' doors and pleas for an improved service. So I'd like to thank on behalf of the EPC, NCEPOD, for allowing us to host your opening event. Thank you very much.
Thank you.
Very good bit of work.
Thank you. Thank you very much, all of you, for your input and support.